In this final session, I want to talk about the possible relevance of these ideas on self-management in resource-poor contexts. And just as a quick reminder as to what I mean by resource-poor contexts, which I mentioned in the first session, where there is a complex health market and multiple providers, some of them qualified, some of them unqualified, some of them definitely quacks, where most things are paid for in cash, even in what we term the public sector, where there's an absence of doctors, nurses, midwives, pharmacists and so on, and where there's heavy reliance on community health workers, village health workers, health extension workers, whatever you want to call them, people with 6 weeks training, maybe 3 months training, who can do the basic healthcare, have no qualification above that. And then enormous variety of unqualified, uncredited providers, a lot of drug sellers, alternative medicine alongside allopathic providers, faith healers, traditional medicine sellers and so on. So a very complicated picture where people are basically looking around for reliable services, where they're seeking knowledge from these various alternative sources, but often with very little guidance as to where to get that knowledge. And we also mentioned in the first session that within a situation there'll be widespread access to mobile phones, so there will be access to people via voice communication, via SMS, possibly via the internet, but probably not. Much less access to the internet than people often assume. Interestingly enough, the self-management model described in the previous session was actually advocated for use specifically in countries where health services could not meet the needs of those with chronic illness. Where there is no possibility of adequately funding a provider-based model of care, Van Ullman and colleagues argued that full self-management facilitated by expert patient networks and smartphone technology is one of the few options for those with chronic conditions. So in many countries who are struggling to provide primary healthcare to reduce the infant mortality rate, to reduce the maternal mortality rate, for dealing with HIV and AIDS, to take on board a new raft of chronic conditions which affect those in older age groups and may require prolonged treatment over months, years. The resource cost of that is often very difficult for ministers of health to take on board. They really don't want to deal with a whole new raft of demands on their relatively limited resources. A recent discussion, for example, in India about whether greater resources should be allocated to chronic illness, and one answer to that has been very firmly that to simultaneously focus on NCDs and communicable diseases, such a utopian argument ignores the political and economic constraints that shape resource allocation. So this would be an excellent idea, and it probably should be done, but it's not going to be done because it's far too difficult to persuade people that this transfer of resources from traditional areas on communicable disease, infant mortality, child mortality, maternal mortality, to chronic illness is just not going to happen in the short run. Self-management may be the only option. We know that there are a vast number of ICT interventions around which are targeting low-resource environments. So there's no shortage of attempts to bring the benefits of E&HEM health to those populations. This is taken from the GSMA Mobile Software Development website, which I refer to in the notes, and they try to keep track of recent interventions in this area. There are a very diverse range of interventions taking place. So, for example, there are, I think as I mentioned in the first session, diverse range, very large number, most of them falling into the pilots category, most of them supported by NGOs, CBOs, international donors, some commercial firms, telecoms companies, etc., mostly on a relatively small scale. So one big area is of health messages, general health information messages about behavior, warnings about tobacco smoking, alcohol consumption and so on, promotion of eating less, taking more exercise, information about family planning options, and so on. So general health measures distributed to the entire population. There's a whole range of interventions which we call targeted SMS messages to registered patients, people who have been diagnosed with diabetes, people who are about to have to give birth. Diabetics will receive regular updates on current advice on foodstuffs, on exercise regimes and so on. Women at various stages of pregnancy will get advice on what should be happening to them and advice on what they should be doing at the various stages of a pregnancy. There are a lot of monitoring systems in process, often involving community health workers with mobile phones, using SMS or voice messages to report back on the progress of a pregnancy, for example, with built-in alert systems so that interventions can be triggered by adverse symptoms, adverse developments during the course of a pregnancy and so on. There's an interesting development in Uganda now, which is monitoring of healthcare providers, health resource information system which provides general population with information about health providers, mainly at the moment on the public sector, but being extended into the private sector, so that you can look at whether people really are who they say they are, something about their qualifications and so on. Monitoring systems on drugs, which again I mentioned in the first session, a group called Sproxil, which I've listed in the notes, authentication of drugs using mobile phone barcodes. Lots of job aids being provided by NGOs, international donors for community health workers. These are often material for use in communication with clients. Videos that can be shown on mobile phones, cartoon drawings, pictograms which can be used to explain the various stages of pregnancy or explain what the symptoms of a particular condition look like. Again, these can be on paper, but more and more they're on the community health worker's mobile phone and can be used in discussion with their patients. A whole raft of guides and training materials. The most recent one that I've come across is the Where There Is No Doctor mobile app, which has now been transferred onto a mobile phone. There's a group called the Mobile Academy, which provides online training for community health workers. There's also, as we mentioned in the first session, a large number of interventions which provide advice, consultations, prescriptions by mobile phone. So we talked about the Healthline in Bangladesh. There's the MeriDoctor and the Mediphone systems in India, which run value-added services over mobile phones, providing either advice or, in the case of MeriDoctor at least, providing prescriptions via SMS to registered patients. So a whole range of these options. What's that got to do with self-management? Well, it's fairly clear that many of the above interventions, though a lot of them are targeted at community health workers, providers, could equally well be used by the patients themselves or by their carers. So they could be seen as contributing to a health information environment that is supportive of self-management. For example, much of the material and many of the tools being used by community health workers, who, as I say, in some countries have 6 weeks training, could equally well be used by patients or carers. And maybe in the case of chronic illnesses, which the community health workers are not particularly trained in dealing with, may be better used by patients and carers who have more invested in providing treatment to themselves or to their family members. There are also a limited number of interesting initiatives in place already which address the networking and support components of self-management, peer group connections, the expert patient option, the links to qualified providers by mobile phone, even self-monitoring. So I'm going to give 3 examples in what follows. At a very basic level, I've been working quite a lot with ICDDRB over the years. With almost no resources, they've set up a series of clubs in the Chikaria region of Bangladesh, where they have a long, long history, probably provide the only reliable source of healthcare in Chikaria. And they've gotten together with local community groups to set up clubs for those with diabetes and hypertension. And they provide them with initial support. They confirm the diagnosis of those who are suspected to have hypertension or diabetes, and then they give advice on how they should behave, what their diet should be like, what their exercise regime should be like, and how they can self-test. Those clubs, interestingly, with, as I say, almost no financial support from ICDDRB, most of them have in fact remained active since 2010, with members coming together at regular meetings and checking blood glucose and blood pressure, using their mobile phones to consult when someone feels they need additional advice or help, or needs to get a referral to go to hospital or whatever. So very local, small scale, initiated by, as it were, a benevolent outsider, but maintained within the community itself. I've also had a long association with an intervention in Cambodia, called Mopotso, on diabetes. This began really rather along similar lines of someone setting up peer groups in Phnom Penh of diabetics, realizing the need. There seems to be a very large, unexpected prevalence of diabetes in Cambodia. Very little availability of qualified treatment. People spend years sometimes trying to find a diagnosis, spend an awful lot of money on useless medications in seeking that diagnosis, and often develop complications before they get any serious treatment. Well, this intervention has grown from these early beginnings of just getting together peer groups to a stage where there are around 140 of these so-called patient information centres for individuals with diabetes now. They're run by peer educators under the supervision of program managers. The program managers are also people with diabetes, so it is very much a peer group operation with some benevolent outsiders, as it were, supporting and helping to raise funds for the operation. The peer groups operate with a small number of local diabetics. Basically, one person in a community is identified as having the necessary skills for a short course of training. They are then encouraged to work within their neighbourhood to find people who may also be suffering from diabetes, possibly undiagnosed. They can identify those diabetics, they can provide advice and information, and assist those diabetics to monitor their own health status. Originally, the idea was that that would be the entire range of operations of Mopotso, but gradually over time it was realized that even if you provided people with information, they still had great trouble finding doctors who were willing to treat them at a reasonable cost and not sell them lots of useless medications, and to find pharmacists who would provide them with the drugs they actually needed, rather than trying to sell them lots of painkillers and placebos. So gradually over time, Mopotso provided connections, as it were, to these patient information centres, which gave them a line to qualified doctors and pharmacists when they needed, and indeed negotiated prices, did deals with pharmacists on bulk purchasing to reduce the cost and so on. So locally organised group, but with links to qualified help when needed. Role of ICT in Mopotso, well, two main roles. One is as the central database of patient records. One of the roles of the peer educator is to collect monitoring data from the patients and feed it into the central database. So they do actually track their patients over time and can intervene when something is obviously going wrong or a patient is demonstrating a worrying trend over time. And they can also check on the effectiveness of the advice and help that they're providing. They can see if patients are actually improving or at least remaining stable under the treatment regime. And then, of course, the ubiquitous routine mobile phone contacts, which actually help to maintain the network. And again, the mobile phone aspects of the program are more or less taken for granted. Almost everyone in Cambodia has a mobile phone, and therefore they can maintain the operation of the network, both locally between the members of the Patient Information Centre, and obviously links to the qualified doctors and pharmacists and to the management, the supervisors and higher management of Mopotso itself. Third and final example is what's increasingly become very popular in the health service field, social enterprise. Again, in Bangladesh, TRCL have set up this system of care for patients with diabetes and hypertension. And they offer basically a range of healthcare services from a mobile phone advice line to inpatient treatment as a an incremental package. So the more you're willing to spend, the more options you have available to you in self-management. So at the base level, there is mobile phone access to qualified doctors. You register with the system, and therefore you can also have electronic prescription. In most countries, only registered patients can be provided with a prescription for drugs. So you do take out a subscription to TLCLM Care, and then you are registered with a doctor, and then you can get these prescriptions. They also offer a home monitoring and home care service, so they will provide you with equipment whereby you can monitor your own blood glucose, for example, and send details of that to the system. And they can also come and help you in your own home, give you advice, give you treatment, prescribe drugs, and so on. And then there is also an arrangement with the Bangladesh Diabetes Association, so that if your condition becomes critical, you can be taken into inpatient facilities. The range of costs for this are between $10 and $20 a month for the home care system. So the registration allows you access to the mobile phone-based services, and then the more you pay, the more services you have available to you through the system, as you might expect. The interesting new development here is the chronic disease management portal. These health portals are becoming a favourite topic in many countries. Essentially, all the data around in the system is maintained in this chronic data management portal. So there is a database there which is maintained of patient records for each registered patient, so they can be tracked over time. And the home monitoring activity can be sent via mobile phone to the chronic disease management portal. Self-management at home, store your results onto the central database, and then if you go through the doctor can access your records on the database, go through your monitoring. Maybe you've been checking your blood glucose for the last 6 months, then the doctor has access to 6 months of blood glucose monitoring in order to give you advice, rather than giving you a blood glucose test and then asking you to come back in a week's time and check again, and so on. So there's a whole history there maintained within the database, which the doctor can refer to in providing you with, hopefully, more useful and effective advice on how you're going and what you should be doing. Those are all very interesting, and one can see that they offer potential benefits, but are we talking about really hopeful developments, or is there a lot of hype involved in this? Well, obviously there's a lot of hype involved because ICTs and mobile phones always involve a lot of hype, and there's a lot of hard sell. This is a commercial area, and you're sure to get a lot of people with telling you all the wonderful developments which are possible now that we have ICTs. One big question, which I think is very important, is whether we're talking about empowerment, good thing, or abandonment, which I think is a bad thing. Characteristic of many new developments in welfare that we talk about empowering people to take decisions for themselves, but then we don't give them the resources to put those decisions into effect. So saying, well, you can now look after yourself, but of course often the people we're empowering don't actually have any resources with which to take care of themselves. We're giving them a mobile phone, but not giving them access to a professional doctor, for example. I'm very worried that in many countries the mobile phone is being seen not as a way of making professional medical services more effective, it's being seen as a way of replacing effective medical services. Big question is, will services be good enough, which is the definition of a disruptive innovation, or a good disruptive innovation, or better than nothing? Yes, if you don't have access to a doctor, maybe it's a good thing that you can ring up a healthline, but that's not really good enough. That's not really a proper health service. That's a palliative in essence for your condition. The other thing which worries me quite a bit is that those are 3 initiatives that I've known about for some time and worked with. I'm very aware that however much the individuals involved say that these are being locally run and are community-based, and local people have been empowered to manage the systems themselves, I'm very well aware that those individuals who establish those systems have been very effective in, as it were, dragging other people along. And whenever any major issue arises, they tend to step in, often to rescue the situation, to raise additional resources, to sort out serious problems, to negotiate with politicians and so on and so forth. They're very much driven by those individuals who came in with the resources, the incentives to drive these initiatives forward. One is always worried that when initiatives are so personal, whether they can be readily translated and taken to scale in or relocated and run by other people. A lot of the academic discussion around self-management relates to a very limited number of conditions. So AIDS, diabetes, hypertension, asthma. So we have a situation where there, as it were, 1,000 flowers are blooming all around specific conditions, not just around cancer, for example, but around breast cancer, pancreatic cancer, very specific conditions sometimes. And each of those groups, each of those advocacy teams dealing with one specific condition. It is concerning if we prefer what I call an integrated healthcare system, where we think about the allocation of resources in relation to need. A lot of work on the so-called burden of disease, so allocating resources in line with the burden of specific kinds of illnesses and spreading the resources around. It is, I think, in danger of becoming a battle between specific disease conditions for those resources, and some diseases are more attractive than others. There's a long debate in the UK, for example, about the amount of money going to breast cancer, for example, as against prostate cancer, because of the very effective advocacy on behalf of breast cancer patients. Are we entering a phase where basically it's going to come down to who has the best advocates, which kinds of condition are most easy to raise public sympathy on, rather than who is suffering most? Some more general concerns. I think it's often assumed that if you can provide people with chronic conditions with information, with knowledge of their disease, it may be a good thing, but it's less of a good thing if there's very little that they can do about it. So that if you have very few options, because you lack resources, because it's very hard to access qualified providers, it may be that knowledge simply leads to frustration, depression, because you know that you're just going to suffer. There's nothing you can do about it. So it's not true that knowledge is power necessarily, unless people have the options to put that knowledge into practice by having power over decision making, effective decision making. The other big general issue is the one I've mentioned previously, that the effective gatekeeping function is essential to health systems and advanced market economies. We long ago in advanced market economies moved away from the idea that there should be a totally free market in selling cures. We regulate. We say that only certain people can prescribe certain drugs. We say that only certain people can give advice on certain conditions. We stop people advertising themselves as medically qualified if they're not. In resource-poor contexts, it's very hard for the chronic sick or their carers to distinguish experts from quacks. And there are an awful lot of quacks who are trying to extract what little money they have. A lot of discussion in recent times about the business opportunities among the so-called bottom billion of poorest people. But sometimes that simply means preying on the bottom billion to extract their meagre resources. Are there potential gatekeepers? Well, we have to think fairly broadly. National and local government agencies, NGOs, gates, funding intermediaries who could provide this role of these are the people you go to when you need reliable advice and information. What about national, international healthcare companies? Do we trust them sufficiently, these large multinational companies who are in the healthcare industry, to provide advice? What about professional bodies? Many countries, professional bodies are a major component of health sector regulation. They prevent their members stepping out of line. They can take members off their register and then they can't practice anymore. So they're very powerful organizations. In other countries, professional bodies tend to be much more like trade unions. Their aim is to improve the well-being of their members, but with very little regard to those whom they serve. What about the drug companies? Do we trust the drug companies to provide the kind of support that desperately trying to build up their value-added services and would very much like to be involved in the provision of care to the chronic sick? Chronic sick could be a very valuable source of income because they're going to be around for some time. They're going to need resources for quite a long time. A regular source of income for drug companies, telecoms companies. Now, before we are too dismissive, I think one very valuable area of research will be to think about whether there is a viable business model that would actually incentivize private companies to provide appropriate, reliable health information and support services to the poor or the poorest. One of the problems with a lot of the pilot exercises that have been set up is that in fact they're not viable. A lot of the social enterprises have actually stopped providing services after a year or two because they had very good intentions, but they simply didn't make enough to even cover their costs, and therefore had to stop operating within a relatively short time. Well, that's not much use. What you need is a system which is providing reliable health information, but also can generate enough income to keep the service in operation over the long term. And I think one possible area we should look at very carefully is whether technology could be in use to enhance regulation. And here I've been looking at the growth of mobile money over recent years. Been around for quite some time now. The transfer of resources using mobile phones. Obviously a target for fraud, theft, but with apparently rather good security systems that can maintain the integrity of those systems. Could we use something rather similar in the effective monitoring of transactions relating to healthcare? For example, could telecoms companies automatically record health-related calls and messages and allow independent auditors to sample those to assess the activities of those offering services? This might be something that governments could introduce as a license requirement on telecoms companies who want to put in value-added services. My basic final comment is that it's very frustrating in a way that the possibilities are so obvious, the advantages are evident, but we're finding it very, very hard to find ways of managing the system in a way which is not open to abuse, not open to making life worse for the poor and the poorest, rather than making it better.